Good morning, good afternoon, good evening, wherever you are in the world. A very warm welcome to Meet Menaca to celebrate you. Today, we are going to be having our episode 59, that is Prevention and Management of Diabetes with Dr. Karunakaran Vithyan. Before we start, a very warm welcome to you, Vithyan. Thank you so much for agreeing to come on the show.
Right, my pleasure.
Just a brief note about Dr. Vithyan. He is a consultant in diabetes and endocrinology. He works as a consultant in Colchester, Essex for past 10 years. He has a passion for health promotion and has been on several public health education programs. So diabetes, as most of us know, it is a very prevalent disease, particularly among South Asians. And it is fair to say we do have a lot of South Asian participants. The prevalence of diabetes, according to statistics, it is including the undiagnosed people, are estimated over 4 million people living in the diabetes just in the UK. So which represent around just 6% of the population. That is 1 in every 16 people. So it is quite common place for somebody to have diabetes, and hence I think it's important for us to know as much as we can how we can prevent and manage diabetes. Without further ado, let's ask the expert. I know, with my limited knowledge, I know there's a difference between type 1 and type 2 diabetes. Diabetes is quite common. As an expert, what would you want the participants to know?
Thank you. So when we talk about diabetes, the diabetes that most people understand as diabetes is type 2 diabetes. That is the commonest form of diabetes or sugar diabetes, or whatever way you want to call it. And out of all of the people with diabetes, about 85% will have type 2 diabetes. And then there's about another 10% who will have type 1 diabetes. And then there's about another 5% who don't fall into either of those camps and have less common forms of diabetes. So if we talk about type 2 diabetes, which is the commoner form that is particularly prevalent in our South Asian communities, it's a disease that is driven principally by obesity and insulin resistance. So what we mean by insulin resistance is that when people put weight around their tummies, that's what we call central adiposity, that weight gets then converted into fat, and the fat cells inside the pancreas and inside the liver prevent the pancreas and liver from functioning properly, and they affect the pancreas's ability to produce insulin. And they also affect the insulin's ability to then work on the various bodies in the various tissues and cells in the body that require insulin for its functionality. So because you need insulin to allow blood glucose to get from the bloodstream into the various cells, to allow the cells to then convert the glucose into energy. The glucose is the petrol that runs the cell's metabolism, and without insulin, that switch that takes the glucose from the bloodstream and into the cells is lost. So in type 2 diabetes, the fundamental problem is driven by obesity. And even before we had the COVID pandemic, we had the obesity pandemic, which was driving a diabetes pandemic. And you can sort of clearly see it within sort of 1-2 generations. There's been a generational shift in waistlines and waist circumferences, and that has meant that the pancreas, which was able to manage blood sugars okay, has been struggling to do so, and has tipped more and more people into that category of diabetes. Type 1 diabetes, on the other hand, is a completely different kettle of fish. And there the problem is that there is an autoimmune destruction of the cells in the pancreas, the beta cells, which produce insulin. So, so within the pancreas, there are lots of different cells, and out of those cells, it's the beta cells that produce insulin. And for various reasons that we don't understand, in type 1 diabetes, there's an autoimmune destruction of those beta cells. There's a bit of a nature and nurture. So some people are genetically predisposed to having beta cells that are vulnerable. And then there's the nurture, which is basically the environmental stimuluses, various viruses, various illnesses that triggers the individual to then develop that beta cell destruction. So usually type 1 diabetes tends to happen in people who are younger, who are slimmer, and usually because the beta cell destruction happens at a much more rapid speed than in which you get it with type 2 diabetes, the individuals will often be very unwell with very high blood sugars at the point of diagnosis. So that's the basic thing. But I mean, it is a little bit more difficult than that, because we know, especially in our South Asian communities, that we're seeing lots and lots of children who have type 2 diabetes. So they're like 10 years old, 11 years old, and they're developing diabetes, and that diabetes is coming out to be type 2 diabetes, because we in the South Asian community are particularly prone genetically to developing obesity around the tummy, central obesity, and subsequently developing type 2 diabetes as well. So in the olden days, we used to be able to sort of say, if you're young, it's likely to be type 1. If you're old, it's likely to be type 2 at age of onset. But now it's not so straightforward. So we as clinicians have to keep our eyes open as to which category of diabetes this particular person's in.
Thank you, Vithyan. Listening to you, a couple of things come to mind, because one, you said nature and nurture, even for type 1, which I thought it was just nature, to be honest. I thought it's like, you're just mostly genetically predisposed. So what is the nurture bit for the type 1?
But so type 1 is basically you need to have an environmental trigger.
Okay.
So you have a genetical predisposition, and then you have a certain viral illness. So there will even be cases like where COVID-19 has triggered an autoimmune destruction. But various viruses, viral illnesses happen in the body, and then the body, because it's got that genetic predisposition, then suddenly instead of attacking the virus, starts attacking the beta cells instead. So that's the nature and the nurture sort of situation. But we do know that there's a very strong, both for type 1 and for type 2, because we know that type 2 diabetes also runs in the family. But if you've got that tendency to have a weak pancreas, as you put on weight, the ability for the pancreas to deal with that is much more diminished if you've got a genetic predisposition.
Thank you. And did you mention that there's a 5% of them this doesn't fall into type 1 or type 2?
Yeah, so there's lots of other causes as well. So for example, some of you might be aware that, like, for example, certain drugs like steroids, people are on steroids for things like rheumatoid arthritis, for other asthma, those sort of conditions. Drugs can cause diabetes. You've got certain genetic forms of diabetes, what are called monogenic diabetes, which are due to gene defects. And then anybody who's got a pancreas which has been completely damaged due to other conditions like cystic fibrosis, or have had pancreatic cancer, and their pancreas has been completely taken out because they need the pancreas to produce insulin. If there's no pancreas, then by definition they get diabetes. So there are other sort of causes. So there are lots of in the medical classification. There are much more than just type 1 and type 2. But for most people's understanding, it's type 2 and type 1.
Thank you so much, because I think, at least for me as well, the nature bit was clear, but nurture bit was much more clearer today. So, you learn every day.
Yeah, I mean, nurture is very important for type 2 as well, because nurture is, the environment that type 2 diabetes is very, very important, because if an identical twin is grown in 2 different environments, both of them have got the same genetic risk, but one person living in a more obesogenic environment is going to have a higher risk of developing type 2 diabetes. So that nurture sort of situation is applicable to both type 1 and type 2 diabetes.
Sure. So, we all agree, you just mentioned as well, the incidence of diabetes is growing. It is a common knowledge. However, I guess what is not common knowledge is why is it happening? As an expert, what can you tell us?
I mean, so basically both type 1 and type 2 are increasing. So the type 2 increase is, I think, more easy to understand because it's being driven by obesity. And the reason that we have an obesity pandemic is because our lifestyles are changing, compared with 3 generations ago, where a lot of things had to be physical. Nowadays, most of the things are being done by machines. So we live in a sedentary lifestyle for the vast majority of us. And therefore, calorie expenditure is much less than calorie intake. So I think for type 2 diabetes, it's relatively easy to understand why it's going up. There are, of course, certain ethnic subsets, like South Asians, like Blacks, who have higher genetic predispositions simply because their pancreases are genetically predisposed to getting diabetes. But across the board, across all population subsets, because obesity is so prevalent, it is becoming an issue. So if you look at sort of even, I mean, we're talking now here in the United Kingdom, where obesity is more of it's a disease associated, a condition associated with deprivation. So the societies with the least amount of wealth and affluence are the most likely to be obese. Whereas if you look at countries like India and Sri Lanka and South Asia, obesity tends to be found more in the cities, the urban areas. And if you look at diabetes prevalence, there's a big disparity between urban India and rural India. Simply, it's being driven by the diabetes, by the obesity statistics. Type 1, on the other hand, is a little bit more difficult to understand. The general feeling is that the incidence of type 1 is increasing because the incidence of allergies are increasing. So if you sort of look across most of the Western world, things like peanut allergy, things like hay fever, cow's milk allergy. So those sort of conditions are increasing compared with like 2-3 generations ago. There's a lot of theories being postulated as to why that might be happening. Some people talk about the dirt hypothesis, like people of an older generation, when they were children, they would have grown in environments exposed to a lot of mud, dirt, general environmental pollution. So as a baby, as a toddler, they would get exposed to all of those sort of things. Whereas now we live in a much more sanitized environment, and therefore when we do get exposed to unusual pathogens, then the body starts to sort of react against this. We don't know. The honest answer is we don't know, but there's an increase across the spectrum of all forms of autoimmune conditions, including type 1 diabetes as well. So that's why that's a long answer, but both type 1 and type 2 are increasing.
As you rightly said, type 2, we all can understand, but however, it's much more complex, I guess, and more difficult for a common man to understand why the type 1 is increasing.
Absolutely.
We all now agree that it is increasing. So as an expert, what can people do to reduce their risk of developing diabetes?
So I think you'll all probably know the answer to that, and that's around weight management. So that's not rocket science on that front. Now, if there was an easy way to lose weight, then we wouldn't be in the situation where we are. I mean, if you look at UK statistics, about 60% of UK population is overweight or obese. And there's increasing prevalence of obesity. The children are more than 90th centile of where they should be for their age in the under 5 age group. So this is a societal problem, and it's a problem across all developed countries, and it requires a multifaceted approach. So a lot of it is to do with, using the car less, walking more. So this petrol shortage might be very good, use the car less, go out and about, walk, cycle, so I think that is part of the equation as to, we need to move more as a society. So when we talk about prevention, that's basically what we call primary prevention and secondary prevention. What we mean by primary prevention is to prevent diabetes in the first place. So that's where healthy eating, exercise, doing walking, trying to sort of, get one of those Fitbits and trying to aim for about 6,000, 10,000 steps a day type of walking, those sort of activities help. Keeping on top of your weight helps. And then there's the other thing that is basically secondary prevention, which is if you do get diabetes, trying to prevent problems from happening. So there are two ways to do that. The first thing, and which is an easy thing for everybody to do, is to know whether you've got diabetes or not in the first place. Because diabetes is a silent disease, and it takes on average 5 to 10 years from the time of somebody getting diabetes to the time that they develop symptoms or complications of diabetes. So during that time, the high sugars are causing damage inside the body's various organ cells, but the individual themselves will be completely unaware of it. So the analogy that I use is basically like a termite infested piece of furniture. The termites have got into the system, and they're sort of eating away from the inside, but you look at the chair from the outside, it looks absolutely fine. So test for diabetes. That's the number one sort of thing that I would sort of say, because the earlier you pick up diabetes, the easier you can do something about it. So that's the number one thing. The number two thing is there are now some evidence-based programs that are there that can help people reverse diabetes. So there have been what we call lots of trials done, which have looked at some specific diets, and these are what we call milkshake diets. So they're basically where the individual is asked to take milkshakes, a milkshake for breakfast, a milkshake for lunch, and a milkshake for evening meal. And then there's a period of about 6 weeks where that milkshake is their meal. And they also have to take vitamins and stuff to sort of make sure that they've got all the micronutrients that they need. And there is so the objective is what we call a very low calorie diet. And with that, there's evidence that about 70% of people who have developed new onset type 2 diabetes can make their diabetes go away. And they can keep the diabetes away for about 2-3 years. So there's a lot of evidence to support that, if for people who have the willpower to do so, this is a really good way. So you do the test, find that whether you're diabetic or not. And then if you do have diabetes, you can take these milkshake diets. So this was something that was pioneered by one of the professors based at Newcastle, Professor Roy Taylor. And his method, it works, really works. For those, so when we sort of say go and get a test for diabetes, the blood test that we do is what's called a HbA1c, glycosylated hemoglobin, and the HbA1c also tells you not only whether you have diabetes or not, but it also tells whether you have what we call pre-diabetes, which is the group before they develop diabetes, because it's not a linear, it's not like a black and white, like one blood sugar, everything is normal. The other blood sugar, it is abnormal. It's a sort of what we call a spectrum of problems. And that pre-diabetes individuals, if you again do lifestyle interventions, you can actually turn things around. And in the UK, we have what's called the National Diabetes Prevention Program, which your GP can actually, it is now available across most parts of England, where your GP can refer you to these programs. And they are sort of programs that are aimed towards providing education about healthy eating, and also education about what sort of activities, physical lifestyle, sort of it's a bit like health coaching, a bit of motivational sort of things, to try to facilitate people towards making the lifestyle changes that they need to prevent them from getting into diabetes. So it was, so in the UK, it was really coming up, and it was getting really established just before COVID hit, which is a bit of a shame. So, and then during COVID, obviously, a lot of these face-to-face activities, group-based activities, they all sort of fell apart. But I think the plans are trying to resurrect them and to get them going. So there's a lot of things that can be done. And I think the key principles really are healthy eating, exercise for all, and then the early know your numbers. If you know your numbers, then you can do something about it.
Sure, I love that. Know your numbers like business. I was really keen to know about the milkshake diet you mentioned from the professor from Newcastle. Is it a particular diet, or is it quite a few different diets available on that?
Well, they've got several flavors, I think, the milkshakes, but it is basically the milkshake. And the reason that they went for the milkshake sort of option is that one of the problems when it comes to dieting, and as I think most of us would have gone through various diets at various stages, is that when you ask people to sort of say, okay, eat a little bit less, how much is a little bit less? You know, so we know from psychological studies that people's perceptions of what they eat and what they actually eat are completely two different things. So when we have conversations, when I have conversations with my patients, and I try to encourage them to lose weight, I never ask them what they eat, because you will end up basically with something that is almost akin to rabbit food. And then asking them to lose weight from what that really sort of tiny portion, which is, you know, not even adequate for day-to-day healthy living, is going to be impossible to advise. So I think it's really difficult to sort of put on a normal diet and sort of say, take only this. Whereas here, with the milkshake, what they've got is it's a milkshake that's been calculated so that they've got about 800 calories, and that 800 calories gets divided over 3 meals. So that's the principle of the milkshake. And then it should be done through a structured program, so that when it comes to the end of the milkshake period and normal eating is reintroduced, it's done in a gradual manner, so that they're not going back to what they were pre-milkshake introduction. There's also in the programs where the programs are available, they also provide these Fitbits and stuff and motivate people towards making the healthy lifestyle changes as well. So it's not just, you know, a 6-week period of thing is not going to turn things around. But what it does allow is it allows rapid weight loss, and it's that rapid weight loss that makes the difference. So this is not a diet to get rid of obesity. And I think that's the really important thing to understand. Most people who get their diabetes go away, they on average they lose about 10 to 15 kilograms. So for some people that might be fantastic, a phenomenal amount of weight loss. For other people, it might be on actually a small amount of weight loss, but that's enough to get their diabetes away. And so the objective of this particular diet is actually not weight loss per se, but it's enough of weight loss to achieve that the pancreas to be given a second chance.
Sure, thank you so much. Because I mean, I know about Pronocal, I know about Cambridge diet. You know, there are various diets. You know, and then people, as you can see, obviously I'm not the slimmest of people. I have tried different things. Yes, perception of it's not only eating; it's in the perception of drinking alcohol, smoking. I think everything is the same.
I mean, a lot of people. I mean, the milkshake diet, of course, is an extreme one, and it has to be done with medical supervision and things. So at the moment in the UK, there are pilot programs for that to be introduced. So it is not available for all areas. And also, especially for people who have established diabetes and are on medications like insulin, for example, doing something like that has to be carefully sort of discussed with a healthcare professional. It's quite a useful thing for people with newly diagnosed diabetes where they're not on a lot of medications, because that they can do that type of extreme starvation safely. A lot of people swear by intermittent fasting. I mean, if you follow Michael Mosley,
Yes.
And his sort of health programs, he will swear by that. And there are a lot of healthcare professionals, a lot of people that I know who are absolutely into it with regards to intermittent fasting. And the principle of intermittent fasting is that you, if you only eat for a few hours in the day, and you give your pancreas rest during the intermittent time, then that allows the body's mechanisms to get better. Is there a lot of science behind it? It's difficult to tell, but I think at the end of the day, it's all to do with discipline. And so you know that you're limiting yourself to a particular time period. There's only so much that you can eat during that time period without getting full. So if you can keep to those hours, I think your total calorie intake over a 24-hour period is going to come down, and that is then going to facilitate weight loss. So it does seem to be working, intermittent fasting. People who have done intermittent fasting and adhere to it do seem to be they seem to maintain the weight that they have lost originally.
Yes, like you said, I know several people who are into intermittent fasting, and I think one thing I do see in them is they're able to keep at it for a longer period of time than anything
it's
else.
Discipline, isn't it? It's that
Yes.
discipline of it's not like I'll have a smaller portion of that cheesecake or a bigger portion of that cheesecake. I can't eat anything at all during these hours. So that all or none sort of thing does make, in some people, it makes it much more easier.
Sure. Thank you so much. And I'm sure, we have learned so much. I think it's important to know the background of these things before we go into managing it. Prevention is always better than curing it. So it's, I think rightly so, you spend more time talking about those things. So what would you say are the top tips for those who have been already diagnosed with diabetes?
So I think these sort of mentions of, trying to get access to these programs to try to lose weight and see if they can make their diabetes go away. That is always, if you can make your diabetes go away, that's the best outcome. If you've got the, in your local area, if that sort of program is something that's being supported, that's something that you can consider. But for the vast majority of people, especially those with established diabetes, it is basically playing the long game with regards to basically screening effectively for complications. So every person, especially in the United Kingdom, every person with diabetes is put on what we call the diabetes register, and then they're called by their GPs at least once a year, often more times, for what we call an annual check. And the objective of the annual check is to screen people for problems. So, so the problem would be doing, blood tests. Are there problems with their cholesterol? Problems with their kidney functions? Urine tests? Is there problems in the wee? Eye test, retinal screening, foot test. Are there problems with, like have they lost sensation in their foot, i.e. neuropathy? So the principle in diabetes is really, a stitch in time saves 9. So if you can prevent problems, or you can pick the problems up at an early stage by doing the annual screening programs, then it allows things to be picked up early, and then the healthcare professionals can do something about it. So I think the first top tip really is for patients, people with diabetes, to know to go and get their health checks, especially, which is a difficult thing in this day and age where, it's difficult to get GP appointments in the UK. But getting that annual check. And then the second thing is really then know your numbers. knowing what those annual checks is, knowing what your HbA1c is. What does that mean? Is it a good HbA1c? Is it a bad HbA1c? Is it better than last year's HbA1c? What's my cholesterol? Is it a good cholesterol? Is it a bad cholesterol, etc.? What's my blood pressure? So those sort of metrics is really important, because diabetes is something where you're in it for your life. So you need to sort of invest into knowing a little bit about your diabetes and knowing what are the important things that you need to look out for, and thereby then intervene. So knowing your numbers is really important for someone with diabetes, so that they can understand and have a very sort of a high-level conversation with their healthcare professionals. The other thing that's really important is statins. So anyone with type 2 diabetes should be on a statin, because the number one killer for people with diabetes is heart disease. And people with diabetes have a much higher risk of developing heart disease, heart attacks, strokes, etc., and dying from those conditions than those age-matched people without diabetes. And the single biggest intervention that they can do to reduce that risk is to be on a statin. So there's a lot of scare stories about statins, of aches and pains and muscle pain, joint problems, all these sort of problems. And we know that a lot of that is driven by psychological problems rather than true problems. Because if you look at the randomized controlled trials where they've looked at statins, the incidence of side effects is exactly the same as in the statin group and the placebo group. The incidence of, they've even done clinical trials where people with statin problems, they've given placebo and they've given statins to those individuals who have so-called statin allergies, and they've developed the same amount of side effects to the placebo and to the statin. So there's a because it's come into the general psyche that statins are associated with muscle pains, it's preconditioned. If you get a statin, you're going to expect a muscle ache. So statins is really important, because statins are the single biggest factor with regards to reducing your risk of developing diabetes. There are also some new exciting drugs that have been recently launched, which belong to the class of agents called SGLT2 inhibitors, sodium glucose transporter 2 inhibitors. And they have been really impressive with regards to reducing the risk of developing kidney disease, reducing the risk of heart failure, reducing the risk of deaths in people with diabetes. So again, these are sort of, when you're needing medications, being on the right type of medication that reduces your risk of developing complications is important. So I think the top tips would be really carrying on with the healthy interventions that you're doing to prevent diabetes, because that, even if you've developed diabetes, the healthy interventions will help to reduce its progression. If you can make it go away with intensive lifestyle measures like the Newcastle 800 calorie milkshake diet, go for it. Regular checks, annual diabetes care program, making sure that all of your checks are checked every year, so that if there are problems, you pick it up early, and then be on a statin. And then there are also these new drugs that if you've got diabetes in the UK and you're not on them, then you should be having a conversation with your GP, like, I heard about these SGLT2 inhibitors, and then the next best thing except sliced bread. Why am I not on them? That type of conversation.
Thank you so much. At least personally, this is the first time I'm hearing about this here too. So
yeah, it's something that's come since COVID. So the data is very, very, very fresh. Sure. On these drugs.
Thank you. So when they have these, are there group sessions when they the diabetes go for the diabetic clinics and stuff? I'm not sure how it works, but
well, most of the clinics and things will be individual, where they get what's called so in an ideal world, what should happen is that every patient with diabetes should be called for what's called a healthcare check, usually with a healthcare assistant.
Sure.
And then they will take the bloods, and then they'll check your blood pressure, the weight, ask you questions. Are you smoking? You do this, do you take exercise, all that sort of stuff. They take the questions, get the bloods taken off, and then you'll be called in again for an appointment with either a doctor or with the nurse to then go through the results. That is how it should work with what's called an annual, that's a diabetes annual check. And there's a lot of areas in the UK where it happens, and there's a lot of areas where it doesn't happen. But I think even if you're living in an area where it doesn't happen, for you to make sure that you're having those checks once a year, especially if the food checks is really important, because otherwise you're not going to know where people have the there's a problem. If you've got neuropathy, if you don't have a foot check, you're not going to know about it.
Sure.
Now, everybody who is diagnosed with diabetes gets referred for what's called diabetes education programs. These are the group events that we're talking about. So there's the common one that we use in the UK, something called Desmond. And it is basically focuses on all of the, the healthy eating, the exercises, all those sort of things that we talked about. And it goes into at a group-based level and trying to do that motivational sort of thing for individuals. And it's quite useful because it allows people with diabetes to be signposted to, where the resources are.
I mean, the reason I asked is myself being a coach, accountability and group sessions sometimes work best, isn't it? Because you feed off each other, you support each other, you're in that environment. So that's the reason I asked.
Absolutely, and absolutely, yeah. We do that for both for type 1 and for type 2 diabetes. There are separate educational courses. Type 1, of course, there's a lot of education involved. The type 1 management is really, really complicated, and we haven't talked about type 1 because it's the less common sort of situation, but their patient education is absolutely paramount. Type 2, I would sort of say, is less complicated in the sense that a lot of the stuff is common knowledge. Being aware of your carb portions, trying to minimize your carb intake, minimizing your calorie intake, taking plenty of exercise. It's stuff that it's told about from primary school age. Do exercise, eat less, eat healthy. That sort of stuff. It's reinforced and done on a group-based session. And because the person's just had a bit of a shock and knowing that they've got diabetes, it sort of they take home the message a little bit more saliently.
Thank you so much. Before going further, I was thinking, so at what stage do patients come to see you then? Because I know you're a specialist in the field. We normally go to the GP and get most of it gets managed there. So at one stage, would they be saying, yes, now you need to go and see a specialist endocrinologist?
So a lot depends on the expertise of the GP surgeries. So a lot of areas have got really experienced GPs who will manage most of the diabetes. So generally type 1 diabetes management is more complicated because there's a lot of high-tech stuff needed. So I don't know whether you've heard about insulin pumps, Libre, various techniques for blood glucose testing, insulin delivery. There's a lot of very high-tech stuff involved in managing type 1 diabetes. So type 1, most of the patient cohort in our hospital specialist clinics will be type 1 patients. The type 2 patients tend to be more of the complex patients where they're not responding to the various treatments and GPs are asking, what do we do next? Should we be thinking about insulin? Patients not keen on insulin, how can we sort of encourage them to go on to insulin? Those sort of conversations. So they're slightly more complicated end of diabetes. But in the UK, we are fortunate because the vast majority of this workload for a very, very, very common condition, it can be done in primary care. Other countries are not so fortunate, so they get referred to hospital clinics, and hospital clinics are so busy. They're really busy clinics, very long waiting times, all that sort of stuff. So I think we're in a fortunate place in the UK.
Thank you so much, Vithyan. These days, not much discussions happen without COVID, right? So why have people with diabetes done so badly when they catch COVID?
So it's a really interesting question because we didn't expect that at the start. So we expected when we first heard about COVID that it'll be like a flu-like illness, causing respiratory problems and causing respiratory failure. And if you remember back in March, April, Matt Hancock was all talking about building ventilators, because that's what we thought the disease pathology would be. But quite early on in when COVID hit us in March, April 2020, we realized that COVID is more like a multisystemic disorder. So so it's not the COVID virus itself, but when the virus attacks the body then starts reacting to the virus, and it causes it opens up an inflammatory process, and that inflammatory process, in many ways, is almost a bit like the pathology of type 2 diabetes, but at a much faster scale. So if you sort of think about, obesity and the obesity-related chemical changes that happen in the body that causes type 2 diabetes and causes the type 2 diabetes-related harm to the heart and all those sort of things, that process is being almost turbocharged when the viral-related immune mechanisms happen. So if somebody already has an unhealthy heart, an unhealthy, what we call coronary artery disease, where there's a lot of plaques and stuff in their arteries that makes them prone to getting heart attacks and strokes, then this basically just supercharges them. So in people with type 2 diabetes, because they tend to have an unhealthy plaque, an unhealthy vascular environment, when they get COVID, they get bad. And what was really interesting in the COVID pandemic is that in people who were known to have diabetes, but their diabetes was well managed, they actually did not do too bad. So the people who did really bad were either they were not known to have diabetes, but were diabetic, but hadn't had their blood tests with their GPs, and they were walking around with really high sugars, or the people who were known to have diabetes, but had poor control for whatever reason. And they were the ones who got bad because they were the ones who were like sitting ducks for this sort of the virus then to sort of really take over the system. And that's why, in COVID, instead of it being people with asthma and COPD, those type of people getting really adverse effects, it came out that it was the older people who were obese, people who had diabetes, people who had pre-existing heart conditions. They were the ones who were highest at risk of developing complications. Of course, that's all pre-vaccination. Now with the vaccines, vaccines have really changed the ball game. And nowadays, the people who are coming into hospital and being really sick with COVID are the non-vaccinated patients. So I think the vaccines have been a game changer.
Now we are talking about booster doses, right?
Absolutely, and I've already had my booster dose. So, yes.
We mentioned and discussed, and you told about the South Asians being the population where the diabetes is very prevalent as well. So why is diabetes more prevalent in some population than others, i.e. like South Asians?
I think there are lots of genetic stuff that we don't understand properly. So I think we are genetically more predisposed. So even if you look at BMI thresholds, so and everybody understands what's called BMI, the height and weight being compared and stuff. So there's a lot of evidence now that the BMI of what's called a normal BMI actually is different for people who are of South Asian origin than those who are white Caucasians. So, so we are, I think, genetically, we are smaller made people compared with white Caucasians. So I think when we have sort of things which are of a similar weight or a similar waist circumference to a white person, we are disproportionately more fatter inside in our body. So even it can be the same height, same weight, but you will be much heavier as a person with more weight around the tummy because you should have started off as a much smaller person in the first place. So I think there are genetic factors. Our diet doesn't help. I mean, very, rice and chapatis and pitu and all those sort of carbohydrate rich foods are not very helpful when it comes to diabetes risk. So when we come into the UK and rice and curry, it would be a big portion of curry and a small portion of rice, whereas for most South Asians, a big portion of rice and a small curries on the periphery. So I think that carbohydrate loading doesn't help us either. And generally, our lifestyles don't help, because compared with a lot of the our British counterparts in the UK, we going to gyms and doing physical activity and keeping ourselves active by running, cycling, jogging, those sort of activities are also on average less. So when I drive by London at times and I sort of go past Clapham Common, the park, almost all the people who are running are in white people. So I think there are factors also in our lifestyle as well, which also influence. So I think it is that nature and nurture combination that predisposes us to have a particular double whammy.
So I totally agree with that. Like, of course, we are, I guess we have been nurtured like that, right? Unless and until you have a full plate of rice or full plate of puto and then a bit of curries, rightly said, in the periphery, it's not the proper food. You're starving yourself somehow. That's the understanding you have growing up. But, why is that, like South Asians in particular, we put on more weight in the tummy area, as you said? Is that also genetically predisposed?
It probably is. I mean, there's a lot of understanding now that obesity is genetically driven, and there are a lot of pathways that drive obesity. But so at one level, you can sort of say that, like, for example, we all know of people who can eat like a horse and can remain absolutely bone thin. And then there are other people who have to be on eternal diets and starvation, otherwise they put on weight. I mean, we all know about that in our own sort of family social circumstances. So obesity or weight, not obesity, weight is a very closely regulated process within the body, and there are lots of genes, there's lots of pathways that work on obesity. And scientists are still not, they still don't have an understanding of all the pathways. But I think I would sort of say that, obesity is not something that, we were not always genetically, we were not always as a species obese. Obesity is a new problem, and it is the environment that's creating the obesity. So I think, trying to find a pharmacological cure for obesity, I don't think it's going to work. You really need to really focus on the lifestyle. So, for example, I mean, if you look at countries like, for example, the Netherlands, where they really focus on trying to get from A to B in a bicycle, trying to make sure that that focus on staying slim, being slow, that is their part of their cultural psyche. They not only if the whole population tends to be slimmer, but when they have less weight, then they also have much less incidence of arthritis, they have low incidence of blood pressure, they have much lower incidence of cardiovascular disease, diabetes, cancers. There's a whole raft of conditions which are weight related. So you find that the investment that you need at a societal level to help people moving, to help them healthy, actually pays off, because you spend much less. Unfortunately, in the UK, we are very much against, our environment is very much against. I mean, children can't be let out of the houses. There aren't safe play areas for children to play around. Children nowadays tend to play in PC consoles rather than running around and playing around in their bicycles or things like people used to do 20, 30 years ago. So I think we are sleepwalking ourselves into an even worse situation when it comes to body weight, and thereby indirectly with diabetes. And I think people in the South Asian community, I think because when we grew up, this culture of exercise wasn't there. So, I grew up in Jaffna during the war. My exercise was cycling, and I cycled 7-8 miles a day just to go to school and all the way play the tuition. That was a really good physical activity. We didn't even think about it as exercise. We just did it. Getting water was from the well. You have to pull it from there's a current cut. You have to draw the water from the well. That was physical exercise. Washing the clothes was a physical exercise. All of those physical activities have been completely gone in a Western civilization, in a Western sort of a way. So I think, those sort of things have to come back. I mean, not all of it, but with regards to the physical activity as part and parcel of a day-to-day life, I think it's going to be very important.
Thank you, Vithyan. I didn't know that you grew up in Jaffna during the wartime, because I grew up in Trinco during the wartime at the same time. Yes, I used to bicycle to school, and it was more fun than exercise. So, you don't even think about it. Yes, of course, I think I did my dentistry in India. Even then, we used to walk a lot. But of course, now it's predominantly driving.
Absolutely, and I think that's our negative sort of thing. I mean, I'm hoping that part of this issue about climate change and stuff, that it'll focus. I mean, electric cars are fantastic, and they do help, but I think we really need to get back to nature with regards to more walking from place to, even if it does take much longer time.
Sure. Like you said, the petrol scarcity might force us to do it.
Yeah, this is a temporary blip. It'll come back.
I can already see so many questions are coming through for me. What are the long-term implications if diabetes is not managed well? I think that is something people miss out very often. And I hope if they know what are the implications, they're more likely to manage the diabetes so much better.
So yeah, I mean, you could spend a whole day on what can happen if diabetes is not well managed. I mean, diabetes is one of those conditions that affects top to tail, every part of the body. Like in medical school, we used to sort of say, if diabetes is associated with this, true or false, you can sort of say true to anything, because there's pretty much every part of the body can be affected by diabetes. In our medical thing, we tend to divide it between what we call macrovascular and microvascular complications. So macrovascular are problems related to big vessels. So when we talk about big vessels, one of them is the vessels to the heart. So it can increase the risk of developing heart attacks, increase the risk of heart failure. Then the other big vessel is the brain, the blood vessels to the brain. So it can increase the risk of getting brain attacks, strokes. And then the other is the vessels to the lower limbs. It can increase the risk of developing foot ulcers by affecting the blood circulation to the feet. And then the microvascular complications is where it's not the big blood vessels that's being affected. It's the small blood vessels that are being damaged by the high sugars. And that can be across the board in any part of the organ systems of any tissue itself. But the common ones that we understand is retinopathy, where the blood vessels in the eyes get damaged, and therefore you get changes, what's called early retinopathy, which are little small bleeds in the eyes, and then as that progresses, the bleeds get worse and worse, and you can lose your eyesight. And then the other is the blood vessels of the kidneys, and that causes nephropathy. And that's then the kidney starts failing, and you go into kidney failure. And then the last one is neuropathy, where it nerves again in any part of the body, but the commonest typical one is nerves to the feet. And then because of a combination of poor circulation due to the peripheral vascular disease and due to the neuropathy in the feet, that combination then puts them at risk of ulcers, diabetic foot ulcers. And if those diabetic foot ulcers are not managed, then they end up those toes and things having to be amputated, because of infection. And then you lose your mobility, and then weight goes up, and then you sort of really vicious sort of cycle. So there's a whole raft of complications that sort of start kicking in if diabetes is not well managed. And that is again why it's I mean, when you do our diabetic foot clinics, that's the worst possible place to be in, because having a foot ulcer, having a non-healing foot ulcer, is the most depressing condition to be. You know, they've got bits and bobs of their toes and foot lost. Their feet are all deformed. They can't walk because of that. They have to hobble. They lose their livelihoods, and it's a soul-destroying condition to be. Kidney failure is soul-destroying, because they have to be in dialysis 3 times a week. They have to come to the hospitals to be on dialysis, sort of thing. So all of these sort of things, a lot of it can be prevented with early interventions. I think the problem is that often, because diabetes tends to get diagnosed when people are in their sort of 40s and 50s, working age adults, often they prioritize their work, their employment, getting a salary, paying for the mortgage, those sort of things over their own health, because at that particular time in their life, that is their number one priority. But then it starts biting them 10, 15 years down the line. And yeah, it is a very, 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 it's part and parcel of, one of the things that we have to do is to talk with those individuals and try to encourage them. But had we been able to intervene at that 15 years earlier, we could have made a much bigger intervention in their lives.
Thank you so much. As they say, isn't it? We human beings, we compromise the health to gain wealth, and then we spend the wealth to gain back the health.
Absolutely, yeah. I think there is a success story, and the success story has been the retinal screening program in the UK, because 20 years ago, diabetes was the single biggest cause of sight loss amongst adults. But now people don't become blind due to diabetes, hardly ever. And that's because the screening program, it picks up problems at an early stage. They get referred for laser treatment at an early stage. And that has, it's really made a difference to so many people's quality of life. So again, it's an example of, if you pick something early and do something about it, you can make a difference.
Sure. Thank you so much, Vithyan. We have learned so much. Just before I wrap that up, can I ask you to say 3 things what people must take on top of their head when they go back from this talk or listen to this talk, must know, even if they know someone who has diabetes, please go and share that to them.
Well, I think the first thing I would sort of say is find out if you're diabetic or not. So know your numbers. Second thing is about that healthy eating and exercise. So if you haven't done so, get one of those Fitbits or even a mobile phone which has got your step count, and try to aiming for that sort of anywhere between 7,000 to 10,000 steps a day type of that target to try to keep your mobility level. That'd be number 2. And then number 3 is that if you are diabetic, make sure that you have your annual diabetes checks, because that's how you pick up problems at a much earlier stage, then something can be done about it, rather than leaving it till it's an end stage complication, and then all the king's horses and all the king's men can't put Humpty Dumpty together again.
Thank you so much. As I call myself chocoholic dentist, I had to definitely listen to this today. So thank you so much, Vithyan. I myself included, I'm sure we learned a lot. For people who are on the Zoom, you know that you have to hold on. We will be going through more questions. Following tradition, I will now announce the speaker for the next week. So it will be our episode 60, and we will be talking about skin health with Dr. Suganthi Devaraja. She has done her MBBS from Madras, now called Chennai, M.Med UKM, and fellow in dermatology, Malaysia. So we will be talking about skin health next week. Now over to Dr. Kanta Niranjan to give the vote of thanks.
On behalf of Meet Menaca, I would like to give a very great thanks to Vithian Karunakaran for a wonderful talk and for your precious time this afternoon. A very important topic. It's more than a pandemic, diabetes, isn't it? You can take people who do not have diabetes, less number than people who have. I know you're coming from a medical family. I know your father was an obstetrician in Eastern Province. During wartime, I worked with him. And it's a great privilege to have you in our forum today, which has a lot of useful information in a very simple language. You explained, and I'm sure a lot of us gained from that. People who are here, they are desperate to ask questions. And again, a great thank you very much. And also like to thank the audience here today for joining with us on this great forum, Meet Menaca. Thank you very much.
Thank you.
Thank you, Kanta. Once again, thank you so much for everybody who joined, as Kanta said, and a special thank you to Dr. Navarindam for introducing Vithyan, because that's how I got to know Vithyan, and it was an incredible session for sure. I'm sure we all will take away a lot from today's session. People who are on the Zoom, please do stay on, because we are going to go through your questions. For people who are on the Facebook listening to us, thank you so much as ever for supporting us. As again, I'm going to request you to subscribe, like, comment, and please help us to help other people. It is a social cause. That's the only reason we do that, is to create social change. So next time we will be speaking about in episode 60, skin health with Dr. Sukanti Devaraja. Now it has come to that time of the day to say goodbye for people who are listening on Facebook. Until we see you next time, same place next week. Stay safe, be happy, and keep smiling.